Recording.
Good afternoon or good morning, everyone. Welcome to the NHSA Monthly Women's Health webinar series. The topic for today is maternal mental health and community clinical integration. Why context matters. But before we get into the topic of the day with our speakers, we're going to go over the agenda. First, we're going to talk about logistics of the webinar, a little bit about NHSA, and then we'll head into the presentation. Then we'll have Q&A at the end and a closing remark. So logistics, there are two ways to listen to the audio. You can listen through your computer speakers or via your telephone, but please do not use both, because if you use both, there may be an opportunity for feedback, and we don't want to disrupt anybody in their listening or in the recording aspect. So listen either through your computer or your telephone, but not both. Please add comments in the chat box so you'll have the opportunity to ask questions at the end. But if you have questions before the end, you can include them in the chat box, and we'll make sure to keep a note of them so that the speakers can answer them at the end of the presentation. Little disclaimer. Thank you for joining this webinar today. So the disclaimer is, it is recorded. You may have heard as soon as you entered, this is being recorded. So because it is recorded, you are, by joining, you are appearing either with your camera or name or name on the screen. If you don't want to be in the recording, you decline your consent, you can leave the session now and watch the recording later. NHSA may be interested in sharing excerpts of this recording in other media channels. If you are featured in an excerpt that we would like to share, we will contact you with request of your permission prior to use. A little bit about National Healthy Start Association. We're an advocacy for Healthy Start programs. We provide training, technical and capacity building, coaching and mentoring, as well as developing and disseminating resources and tools. Now to our speakers. Dr. Fleeta Mask-Jackson is the president of MAJACA. Please, sorry, Dr. Jackson, if I pronounce it wrong. A national research firm / think tank and leader of Save 100 Babies, a cross-sector network devoted to a social determinant approach to equitable birth outcomes. Dr. Jackson has served as a consultant / advisor and collaborator with organizations such as the Harvard Medical School, the Ford Foundation, W.K. Kellogg Foundation, and as a member of the advisory committee excuse me, on health disparities for the director of the CDC, and as a member of the Secretary's Advisory Committee on Infant Mortality. Dr. Jackson graduated from Spelman College and in the University of Illinois, and is the recipient of the Spelman College Alumni Achievement Award in Health and Science. She has been honored by the Black Mamas Matter Alliance for her MCH research and work by the National March of Dimes for her contributions to that organization and the field. Dr. Jackson has been previously involved in the National Healthy Start Association, most notably as the author of our Stress and Depression Toolkit. Dr. Jackson's role on the AMCCI grant is as a subject matter expert. And our second speaker of the day is Deidre McDaniel. She is the president and founder of Health Equity Resources and Strategies, also known as HERS. With over 20 years of experience in maternal and child health, Deidre McDaniel provides guidance to healthcare systems and public / private organizations on how to successfully implement and sustain equitable programs to address disparities. Deidre is also a PhD candidate at Morgan State University with research interests in anti-racist healthcare practices and eliminating disparities in birth outcomes for Black women. As a licensed certified social worker, she has dedicated her career to improving health outcomes for women and children. And as a leader in the field, she utilizes effective communication and sound content expertise to assist organizations with operationalizing their visions for creating innovative cultures of equity. Now, without further ado, I'm going to pass it over to Deidre to start the presentation. Thank you, guys.
Thank you so much, Brittany, and thank you all for joining us today. Before we get started, we wanted to take a quick poll to see who's joining us today, and more so the types of services that you provide. So feel free to put your organization or the name of your organization in the chat, or your general location, as Brittany has the poll up and running. And we specifically wanted to know, by getting this information, if your organization provides mental health services such as screenings, assessments, treatments, or even referral services. So that was the main question. Oh, everybody's all right. So far we have 79 participants on the call, which is great.
Great. Great.
Just give it like a couple more seconds. But I think we got a pretty good gauge here that just from the poll that most of you, 93% of you on the call provide some type of mental health services, which is lovely. Because today, Dr. Jackson and I are going to be discussing maternal mental health within communities of color and why context matters in screening approaches. So we will also discuss how to utilize data from individualized screenings to address community-wide mental health issues among women of color. Next slide, please. And thank you so much for the poll. Awesome. Right, trying to get the poll. So I just wanted to center the discussion as to why this is important and to get a really good understanding as to how we came up with this topic. So when working with women of color, we just want to make sure you understand it's important to make sure that you're considering the role of race, gender, history, and the environment in your screenings, assessments, and treatment options. According to a 2020 study by SAMHSA, individuals have increasingly sought mental health services, yet most of the theoretical approaches out there that are being used currently in the counseling profession or in the mental health profession were not developed to meet the specific mental health needs of Black, Indigenous, people of color clients. So the inability for groups who have historically been marginalized to discuss racism is detrimental to their overall psychological health. Therefore, providers such as ourselves need to be comfortable with discussing these issues, even if you are not from the same racial background. So even if there's not the same racial concordance, we still need to make sure that we're prioritizing these discussions in each and every interaction. There has to be an understanding of the concepts of race and the importance of allowing room for clients to discuss. Otherwise, screening and treatment for perinatal mood and anxiety disorders are further impacted by patients' lack of trust in their providers. It's also important to note that race-based traumatic stress can occur whether incidents of racism are overt, covert, or vicarious, which means that the trauma doesn't have to be due to an incident that directly impacted our clients. Community acts of racial violence and brutality are also contributors to race-based trauma. Furthermore, as it relates to women, which we're talking about today specifically, gender racism has been linked to traumatic stress disorders, anxiety, and depression. And women of color are at increased risk of experiencing perinatal mood and anxiety disorders and face greater barriers to high quality mental health care. And lastly, but certainly not least, maternal deaths due to mental health disorders are on the rise, especially during the COVID epidemic, with nearly 3/4 of people with a pregnancy-related mental health cause of death had a history of depression. These numbers are even higher for women of color. Collectively, individuals develop their sense of self from their environment, social networks, familial and community connections, educational experiences, and lived experiences. However, for women of color, the chronicity of racism impacts the perception of self and can result in negative coping mechanisms such as avoidance, self-blame, suicidal ideations, and substance abuse. So the more communities of color are exposed to gender racial microaggression, the higher the risk of developing traumatic stress symptoms due to internalized racism. So next, Dr. Jackson will expand on this issue and discuss the role of stress and the importance of contextualizing stressors for women of color and how to use contextualized stress measures as a screening tool. Dr. Jackson?
So before I get into stress, I want to share a historical moment. First of all, hello to everyone. I'm in Atlanta, Georgia, so I bring you greetings from LA, love Atlanta, as we sometimes refer to it. Here in Love Atlanta, there was a woman in the 1950s by the name of Dorothy Bolton. Dorothy Bolton had been a domestic really all of her life. Even as a child, she started doing domestic work. And on one evening when she was leaving from work, she lived on one side of Atlanta, the north side or the south side of town. Her employer lived on the south side of town, north side of town rather. And so Dorothy, there was quite a dance you had to do to catch the bus to make sure you got the right connections to get home on time. She had a family to take care of. So when she got to the door, her employer, who was a white female, who she worked for all day, she would get to work at 8 o'clock, having to get up at 4 o'clock in the morning in order to get the bus to get there on time. And we're talking around the 1950s for her story. So anyway, Dorothy, her employee said, "Oh, you left some dishes in the sink." And so Dorothy knew she had to get home or she would not be able to feed her children, take care of all the things she had to take care of at her own home. So she proceeded to walk on out the door. Well, when she walked down the street, all of a sudden she heard this car pulling up next to her. It was a police car. The police came and took her and they arrested her. And they told her that she must have been crazy to have talked to her employer like that. They detained her. It's much like a syndrome in slavery when slaves would escape. They said they had a mental illness for running away. Well, it was Dorothy saying, you know, I had to go on. So Dorothy was detained in the police station for several days. Ultimately, she was released when professors from Atlanta University, which is the oldest institution of higher education in Atlanta, which was founded for and by Black people. Dorothy Bolton's, those individuals did an assessment, a screening of her to indicate that she was not mentally ill. So there are a lot of things in that story. There's what get categorized as some mental distress, mental disorder, so forth, as individuals are in resistance or resilience against those circumstances they find themselves on account of race. It also says something about the assessment and screening of her for those individuals from Atlanta University who could both qualitatively and quantitatively confirm that she was not mentally ill, but that there were circumstances surrounding her. So I share that story. I've been thinking about Dorothy Bolton and what the whole overall context of stress is for women of color and specifically Black women. So we're in an important moment at this time because of COVID that all of us recognize mental distress that has taken place over the last 3 years. We acknowledge it. We see it in ourselves. We see it in each other. We're doing different things to remedy it, but we know that it's real. There's not somebody else. We certainly are beginning to see different phases of it, severity of mental distress, and we're seeing depression and anxiety. And so the Prevention Council recently released a recommendation for us for anxiety, for anxiety testing to take place, you know, so the prevention of anxiety, and to also look at the Prevention Council also has looked at depression before. Healthy Start has certainly been ahead of the game in terms of depression screening. That is something that you're mandated to do. And I applaud you for that because it doesn't happen for pregnant women everywhere, but it does happen for those who are enrolled in the Healthy Start program. Just as depression was recommended by the Prevention Council, anxiety screening is now being recommended by the Prevention Council as for pregnant and for postpartum individuals. So I'm glad to see that that is on the menu, that is part of the standard of care that has been that's being highly recommended. And of course, in a time when we are more when I said we, the larger population does understand what mental distress is, what mental illness, what depression feels like, and certainly anxiety. So I have for the last 20 years been engaged, 20 plus years engaged in studying, in screening for and evaluating stress and its impact on pregnancy and more recently postpartum outcomes, to see what is this thing that we all talk about. We are in an era where everybody talks about stress. As a child coming up in the 50s, the adults in my neighborhood didn't necessarily talk about stress. They talked about people being worried, but they didn't talk about stress so much. But stress is the vocabulary of these times that all of us in one way or another understand. And we know that stress, and I'll give some definitions around stress, but stress, we know there's a risk for depression and anxiety. And so it is implicit and to some extent explicit in the recommendations of the Prevention Council in terms of stress. And we also understand that it's not only a risk for those psychosocial risks for pregnancy, that is depression and anxiety, but that it also is associated with hypertension, heart disease, diabetes, and other chronic illnesses that pose risk for pregnancy and postpartum outcomes. I was thinking about this morning since the FDA has just approved medication for preeclampsia, which to assess for preeclampsia and part of the treatment modality. But I've also thought about, and what will they do about stress as well? Because that is a contributor along the way. So next slide, please. So stress in a kind of global, this is really a general definition around stress. It deals with environmental exposures and physiological responses. And I will add psychosocial responses as well. So it is both the exposure and the response. And when we're talking about stress, we're both talking about the way that we feel, but we also oftentimes talking about what are those assaults, what are those interruptions to our goals, our objectives, our ways of going about our lives as stress. And stress can be expectations. In other words, what is it that we expect in our lives, both at a micro and a macro level? When we get up in the morning, we expect that there will be certain things that will be in order. They could be out of order for various reasons. It could be the weather. You get up in the morning and no electricity is on because it was a bad weather event that took place. Or it could be something macro. You get up in the morning and there's been total disruption. And we certainly have seen the macro of the macro in terms of COVID. You got up in the morning, you couldn't go anywhere. So that really was a real joke to our expectations, a joke to our interruption, the way that we went about our lives. And it was the threats. What were the threats? What did those things represent as threats to our well-being, threats to our going about our lives, threats to those we care about, threats to our community? So stress encompasses all of those things: expectations, interruptions, and threats. Now we talk about stress in certain kinds of categories, I would say. Chronic, acute, and traumatic is just three that I will mention right now. Chronic is those things that happen on routinely, rather we anticipated. It could be stress around how am I going to get to work, what route am I going to take. Like I said, I'm in Atlanta and we have atrocious, we have outgrown the traffic. We have outgrown the population in terms of having better management of the traffic flow. So that's a chronic stress. For some people, it's every day, someday they don't know whether they'll get to work 15 minutes ahead of time or if they'll be a half an hour late. So that's a chronic kind of stressor. Or acute stress. And acute stress is something that presumes, and I want to underscore presumes that there's a regular pattern in one's life and that it gets interrupted by major events like death, losing a job, losing a loved one, relationship issues, and so forth. And then finally, there's that traumatic stress. Traumatic stress, and we often think about traumatic stress when we see the weather patterns, the weather interruptions from hurricanes or tornadoes or what have you. Now, we do think about these in discrete ways, but the reality of it is these things are oftentimes occurring simultaneously. So you have these chronic stress that are daily in our lives, but the acute stress comes on top of that. And the traumatic stress can come on top of that. And then for some populations or individuals, what may seem acute for others is chronic for them. So if someone is in a community where there's a lot of death in the family, in some senses, and I don't know what the actual numbers are. I mean, I'm in a research mindset, so I don't know what the numbers are. But right now, what strikes me is the increased numbers of deaths. And I don't know if that's a sensitivity because of COVID. And I'm talking about in the settings where I live and work and play, one of them being in a religious setting. So we have a lot of funerals, at least once a week, sometimes twice a week. And so that has moved from being, oh, we have a funeral and we're so sorry that so-and-so died, until, okay, we buried this one, we're having a funeral for this one, we're having a funeral. So that what would have been acute is seeming to be more chronic. And then what was once considered traumatic outside of the realm, as we look at environmental forces that are changing. So I imagine there are communities now where the traumatic, and as Deidre so eloquently said, it's not just what you experience, it's what you anticipate, or it could be vicarious that is in the mix now. So I say, my point is that all of these kinds of stressors can occur simultaneously. And the impact on health is accumulative. It happens over time. The weathering phenomenon is something that has certainly been talked about recently with Geronima's recent release of her book. But the weathering presupposes that there's a time where things might be leveling off, but in fact that over time, from adolescence to young adulthood, that these stressors accumulate so that by the time an individual is in childbearing years, the effects of that stress can be deleterious for health, for birth, and for pregnancy and postpartum outcomes. Now, all of this doesn't happen in a vacuum. It doesn't happen in a vacuum, although we do for purposes of being able to compare across populations. We do understand that there are some things that are generalizable to human beings, that there are some things that all people will experience. Death and dying in the acute bucket is certainly something that people, regardless of where they are, may experience. There are acute stresses about trying to go about your daily life to take care of yourself, or your family, or your community, that may be generalizable to an extent, to a point. And there are things that are traumatic, that a community being wiped out is a community being wiped out. And so there are some basic things that are losses that happen in that situation. And thank goodness for those people who are part of the disaster emergency group who really are prepared for that, who know exactly what to do, what those basic human needs are. But that doesn't always get to what's core to those stressors. If you go back to expectation, interruptions, and threats, those expectations come from lived experiences which are connected to identity, which are connected to history, which are connected to culture, which are connected to all of those things that individuals living in, that both individual and collectively affect what people expect in their lives. And when those things are in any way threatened or interrupted, it is the basis of that, of gender, race, class, age, history, culture, etc., that we begin to interpret that as stress. This becomes very important because the way that we do our work and the way that we do our assessments and our screening is comparative. We look at one population versus another one, or even if it's not said, there is a benchmark to which we compare everybody else's scores to. And unfortunately, what that does is, for a certain population, it means that they always are inadequate. It gives them no basis for what their strengths and resilience is in terms of addressing those things that come in their lives. And so context really matters in that sense. I don't know of not just about any paper that you read that is talking about disparities in birth and postpartum outcomes and physiological outcomes related to birth outcomes and psychosocial outcomes related to birth outcomes, that the conclusion in the discussion section of the paper, they don't mention something about in particular when talking about Black women, about the unique racial and gendered experiences that Black women have as contributors to the results. It's put in the interpretive frame, but not as part of the assessment. And so that is our challenge, that is our opportunity, that has been the driver for the work that I have been engaged with in, as I said, over 20 years, is to go back and look at what are the questions that we ask in the first place, and how do we get to those questions, and to illustrate how context matters. Context, again, from identity experiences of race, of gender, of class, of age, and just going right out into what are those identifiers that people embrace. Next slide, please. So again, stress, okay, this is a little, okay. Stress is defined as an impediment to our goals, shaped by experiences, expectations, and experience. Stress is both accumulating exposures and responses. So, and I want to emphasize that there's exposures and then there are responses. Now, allostatic load responses and composite. So stress is composed of stressors and mediators as well as affective responses. So let me repeat that. If you look at stress in its component parts, if you were to break stress down, whether it's chronic stress or traumatic stress or acute stress, there are components to it. There's one, the exposures that accumulate over time, as I said before. Then those are the stressors. Then there are mediators. That is, what is the response to those stresses? What are the things that individuals employ? We think about this as coping. We think about this as social support. All of those things, what is employed? And then there's an affective response. How do people feel? So I want to exposures, mediators, and then affective responses. And depending on the measure, one or two of those things might be assessed, or all of them might be assessed, or only one. Oftentimes, when we're talking about stresses, we really are talking about those environmental assaults. But in actuality, stress is that gumbo, if I will use that term, of all of those things converging together. And sometimes in our assessments, whether we use quantitative or qualitative assessment, we're trying to get at a little bit of all of it. We're trying to get at, okay, what caused you to be at this point, this stress state, this heightened stress state, meaning that you have accumulation of it, has caused you to be at this point. What do you do when you get to this point? Whether that's effective or maladaptive, that will certainly be something in a clinical setting could be determined. And how do you feel? What are the emotions that this brings about as the result of the exposure you're coping with it, or the resources that you bring to bear? So it's all of that. Now, in allostatic load, we talk about where you have constant stressors that far exceed the resources for dealing with those coping resources. So you have all these things that take place, and you don't really have enough resources, whether that be in human resources, whether that be in material resources, whether that be in emotional resources in terms of what you have used that have been effective, whether it be community resources, that none of them are effective. And if they stay at that imbalance, where the stresses are high and the resources are inadequate, it creates physiological responses that, if they're not mitigated, they can cause physiological as well as psychosocial adverse outcomes. So in this situation, if we think about stress as this imbalance, if we think about stress in terms of its genesis, its core, it's kind of at its core really those identity factors. If we think about stress as those identity factors around race, around gender, around class, around age, around any number of things, the question becomes, how do we incorporate that in a way that both gives us an opportunity to assess those stresses and to intervene for those stresses? So in my work, my colleagues and I, Carol Hogue, Mona Phillips, and Tracy Curry Owens, we have really conceptualized the idea of contextualized stress. And just as it says, it is stress that comes out of the contextualized experiences of populations, because it wasn't just individuals, but a population of individuals. In this case, it was African-American women from which this kind of notion was conceived. Next slide, please. So what do we mean by contextualized stress? Again, as I said, contextualized stress comes from the lived experiences of individuals that incorporates the identities which they both have embraced and have imposed upon them. Because there's an identity which we may say, this is who I am, but some other things are imposed upon you. And it was the result of a rather rigorous process for going into communities of African-American women and continue to go into communities of African-American women. If I step back in terms of why so much emphasis on stress, in the late 1980s, research was done comparing the birth outcomes of well-educated Black and white women. I am in Atlanta. Atlanta is the home of the largest historically Black consortium in the country, if not in the world. Meaning that since right after the Civil War, the first institution of higher education, that is the first college education, the first college or university that was established in the city was established for African Americans. And that Atlanta University enrolled Black women. So from the 1860s on until the present day, there's a long history of Black women being college educated in this city. In the 1980s, a study was done comparing the birth outcomes of Black women from the Atlanta University Center, specifically Spelman College, which was founded in 1881, with women from a college, Agnes Scott, which was predominantly white then. It's very much more diverse now. But at the time, the comparisons was to look at the birth outcomes between these two institutions. And much to the surprise of the investigators, the Black, well-educated African-American women's birth outcomes were worse around preterm low birth rates. Subsequent studies, fast forward, have still shown that well-educated African-American women are at greater risk of having babies born preterm low birth. And as we are certainly focusing and giving the much needed attention to maternal mortality and morbidity, we see that well-educated African-American women are at higher risk than their white counterparts, even their white counterparts who have less than high school. So this really brings to the forefront the question of, if this is the case, then why is it women who presumably have access to good health care, have a knowledge base about what it is that they are to do, why is it that college degree is not as protective for their health as we would expect it to be? So we embarked on a journey, a research journey, a research line of research, I will call it a line of research, to explore what was it about being an African-American woman, whether she was college educated or not, that presupposed those individuals from being at greater risk of having having adverse maternal and pregnancy outcomes. And so it started off asking women, or showing individuals, and including Spelman graduates and individuals from everywhere, quite frankly. The point of entry in terms of Black women's communities included individuals who were graduates of HBCUs, including Spelman College, women who are not graduates of HBCUs, individuals who were in church groups, individuals who were in high-end subdivisions, who lived in high-end subdivisions, but also individuals who lived in the housing project, women who were in church groups, women who were sororities, women who were in work settings, including Grady Hospital and other places like that, to ask them, one, what was their explanation for health disparities, not just birth outcome disparities, but what was their explanation for those disparities? And inevitably, after they gave the usual explanations of health, of dealing with diet and exercise and poverty and all of that, inevitably they said stress. So that started off our journey. What was stress? What did it look like? The exposure, as I talked about before. What did stress look like? The next question is, what did you do about the stress? And what did stress feel like? And so listening to over 300 individuals, again, from all walks of life, community-based, so the ages really were pretty widespread from 17 to 77, but when you go in the community, you can't tell people you can't be in it and you can be in it. When you go into focus groups and other things, and it was valuable information, because it then gave us some information to talk about generational, or at least a way to think about generational stressors for women who are younger, women who are older. And so again, where they live, work, play, grow, all of that. it was really determined. I want to underscore a determined approach, because as we have been in this Healthy Start enterprise, which has been, I will pause now to say just how enjoyable it has been for me to work with the colleagues who are the other consultants, quality improvement, and all the other things which they have taught me the language of that enterprise, and what it has certainly stretched me and gave me some sense of how the work I've been doing so many years might fit into what is needed in order for us to get to the another step. I will say this: we are in the middle of a tsunami in terms of birth outcomes, in terms of postpartum outcomes. And the only way to get out of tsunami is to go to higher ground. And so I'm glad to be with them as we really march toward higher ground. I just wanted to pause to say that. What the women told us was all the things that were going on within their lives. And we listened to them in focus groups, and we listened to them in interviews, and we took the focus groups and the interviews, and we, I'm not gonna say translate, I'm gonna say transcribe, because the statements are written in a way that even whenever women take the tool, they say, oh yeah, I recognize this. Have you been in my diary? Did you know that I said that? Because we wanted it to be that culturally congruent as possible, okay? As culturally congruent. That led to subscales to deal with racism and gendered burden and abuse and neglect and workplace stresses. And stress mediators were around things like social support and history and culture and religiosity and spirituality. And then effective responses when they said, how do you feel? Women talked about being lonely. You know, loneliness is certainly high on the agenda of the Surgeon General, as it should be now. We really do have to deal with what this social isolation that has been underscored as a result of COVID, but it was there before. It was there before. It didn't just pop up now. It was there before. Loneliness, fear of failure, suppression of anger, and just feeling overwhelmed. And so there's a whole process that you have to go through to create a tool. There are a lot of surveys that are around, but surveys don't necessarily have to go through what we call psychometric standards. Psychometric standards means that they have to be validated with existing tools. Now, you could say, well, you know, this kind of tool, and there are others like it too. I won't say that this is the only contextualized. This is kind of our construct, contextualized stress. I would say there are other tools that are increasingly looking at specificity in terms of the exposure. I was reading the other day about a tool that has been developed for male depression. Why? Because it recognizes that the tools that we use for females miss the manifestation of depression in males. I would argue that's a contextual kind of approach that comes out of specific context that understands that both the expression and the identification of depression, or for instance, the strong Black women schema is also another, I would say that it comes out of a context to say, you know, this is the way Black women have been socialized to present themselves in terms of dealing with the things that are in their lives. So this is a way that is very specific, but at the time we did this, we really didn't have other tools to validate against, because we talk about construct validity. And construct validity really deals with those measures being real clear about what they're trying to measure. And in fact, does an existing measure, is there association between an existing measure and your current measure? And we did have construct validity in terms, but also reliability. And reliability means the stability of a tool. So we had to do test and retest. So we went to women and asked them to finish out the pilot items, came back and did it 30 days later to see if there was stability in the measure, and it was. So that's kind of in a nutshell. It's really quite a labor of steps that have to go through when you talk about validity and reliability of the tool. Next step, please. Next slide, I mean. So I've already said this, but one of the things in the last part of it, we had community feedback. So by the time we got to something that we thought was in the final form, we went back to communities of individuals who had participated. And they told us, okay, that makes sense. That doesn't make sense. Take that out. We didn't say that. So there was another step in terms of community-based methods for developing the tool, in which community came back and evaluated what it was that we thought would be the final steps for creating the tool. So next step, please. Next slide. Contextualized stress, and contextualized stress comes out of a notion that the theory can be grounded, that it builds upon those lived experiences. And we call that grounded theory. Grounded theory looks at what are the theoretical components that come from that qualitative data that then build up a theoretical basis for development of what it is that you're trying to achieve. Intersectionality, where class and gender matter and converge, they're embedded in history, culture, and other factors. And so, when I started out with Dorothy Bolton certainly represents something in terms of how mental health could be weaponized. I will say mental health was weaponized against her because she resisted to what was taking place in her work environment. But it also, stress is a very interesting thing. In evolutionary terms, we think about stress in negative terms, but in evolutionary terms, stress is the basis for growth. So if an organism is stressed to a point that it creates something new, you can say it's the basis for growth. And so Dorothy Bolton's situation became a basis for growth. And I'll just pause here to tell you a little more about her, because what happened was Dorothy Bolton became a major figure in domestic workers organizations. She fought in the city to make sure and began to desegregate the buses to make sure that domestic workers had the transportation that could get them to work. Okay, and then she went on to the next step with the encouragement of Dr. Martin Luther King. She lived in the same neighborhood where he resided. And with the encouragement of Dr. Martin Luther King, she organized domestic workers, thousands of domestic workers, and was certainly very instrumental in making sure that domestic workers could get Social Security. So again, stress, I'm talking in political, social, but for the individual, stress itself can be the basis for evolution, for moving into another plane. And different strokes for different contextualized stress. The last point I want to make is that this work and other work that I think is emerging, I'm excited to see other work emerging. I really am, because I think just as you have a whole menu of measures for stress, for depression, I want to see a menu of measures for this kind of approach as well. And so core to it is that Black women are authorities on their lives, recognizing both threats and protections. And I say for any group of women, Native American women, Latina women, that they are authorities on life. They know what is the stress points for them, and they know what they need in order for them to overcome. Next slide. So the latest version of this stress is a 56-item Likert scale comprised of, again, stressors, of racism, burden. Burden deals with gender kinds of things that are specific in terms of women's roles and responsibilities, both embraced and imposed. And I think it's important you understand that it's not just that it's embraced, but it's imposed. Workplace stressors, stress mediators, social support, history and culture, spirituality, and religiosity. And there's significant association for the total JHP, again, which deals with gendered racism, because remember I said it's intersectional. Gendered racism and its prediction of depressive symptoms, antenatal depressive symptoms. We haven't really done a lot in terms of postpartum, but antenatal depressive symptoms is significantly associated with perceived stress, which is something that is widely used. Sleep disorders, which is a new finding for one version of it, and life course SES. In other words, it didn't matter whether individuals were grew up in a higher SES category, that we found that these relationships between the JHP and depression were maintained, regardless of where individuals find them, where individuals started out in terms of SES. Next slide, please. So these are just some sample questions. My work is used to judge the abilities of other African Americans. Because I'm a woman, my employer is not usually open to suggestions from me, race and gender. I have to go outside of my community to get the things that I need for myself and my family. I have been unable to provide for my children the way that my parents provided for me. I have to support family members who do not live with me or who live with me. I have a lot of financial pressure. I'm taking care of everyone, but no one is taking care of me. And I have experienced sexual abuse in my relationship. Next one. And I'm not going to read. I'll go to the next one. Next slide. My participation in religious institutions or spiritual institution or spiritual affiliation gives me a sense of community. I can be myself with my girlfriends. My African American heritage gives me the motivation to perform in my job. Next slide, please. And these are the affective responses. I'm worried I'm going to fail. I feel that I'm alone. I feel that I cannot express my anger, and I have too much to do. As the way that the affective, the feelings that individuals express. Next slide, please. So these are just some findings. Higher JHP scores are predictive of depressive symptoms. Individual items contribute to predictions JHP to depressive symptoms. And what I mean by this, we think about this in terms of subscales and then the total score, but then there are individual items that themselves are significantly associated with depression. So in the kind of evolution of this instrument, it both provides a way of looking at individual items, but also looking at the composite scores from either the subscales or all the subscales together. And for that reason, we would assert that its use is both for clinical and community assessment of mental health outcomes, risk, and resilience. What I mean by that, if in fact you were looking at a community and you see that a lot of them indicate that they have that there are incidents of abuse, whatever that abuse may be, or that financial issues are there, whatever those financial issues are, or concerns about children. So for instance, we looked at an item that dealt specifically with concerns about children having negative exposure to the police. And these were individuals who, if they had children, their children were under 5 years old, most of whom were pregnant. But what we found was that those individuals who responded positively to that item, and that they were at greater risk of showing depressive symptoms. In other words, even when the child was in the womb, they were afraid about them having negative encounters with the police. And so that coincides with other studies, population larger epidemiological analysis, which is looking at the effects of unjustified police violence on pregnancy outcomes. Next slide, please. So again, I'm going to end here because this is Deidre, but I'm going to say where this fits in this clinical community integration. The JHP was not designed as a clinical screener. It's not a clinical tool in the sense of looking at looking at systems analysis. It's not that kind of, we didn't ask them, well, that's not right. We didn't ask them about what their experiences were in a clinical setting. We asked them about that. They told us, because remember the process was, what is stress? And they told us about what was going on in the neighborhoods, what was going on in their workplace, what was going on in their relationships, what was going on in those places that they encountered. And they didn't really emphasize the clinical setting. But I think this expands or fits very nicely into what AIM CCI is doing in terms of bringing all of the elements together around what are risks for mental distress that put infant and mother at risk. So I'll turn it over to Deidre. I've said enough.
Thank you so much, Dr. Jackson. Dr. Jackson and I don't present often. We've presented before on mental health, but we have many, many discussions in the work with Healthy Start. And I always see these discussions as a master class. So I just want to take some of the things that she addressed during her part of this presentation and sort of drill them down to what we mean by community clinical integration. Dr. Jackson basically has been speaking about how we need to broaden our view of how we look at stress and the physical and mental toll that it takes. And one of the things that you stated, and I quote, I'll see if I'm going to put this in a dissertation somewhere, but it is a quote.
All right. Whatever gets you through.
Whatever gets me through. We have the opportunity to address the stressors and develop a point to intervene. And how do we go beyond the screening and assessment and expand our means for intervention? And that's what this clinical or community clinical integration is about. When she stated that this wasn't built in the clinical environment, it wasn't a tool that was created like most quality improvement or screening tools in the hospital setting or for the clinical environment where we're providing services in a situation where we don't have a lot of time, where I'm a maternal child health social worker. So I remember those days in the hospital setting where I had 3 days potentially, and this was back in the early 2000s, late 90s. I don't know how long women are staying in the hospital now, but 3 days to establish a relationship, do the screenings, provide the resources and get them out the door before they were discharged. So this tool being built in the community setting gives us more opportunities to have touch points with the families and the women that we serve. So we want to take those opportunities as stress points, opportunities to assess and screen for these stress points, to dig a little deeper. And we can see how with this model of community clinical integration of how that one touch point with an individual doing a screening, how that can impact our organizational programming and then our communities in general, and then how that data from that can really guide organizationally what we want to do and our community-wide interventions. You know, Dr. Jackson, when you talked about stress in evolutionary terms, and you talked about, sometimes stress is good stress and sometimes it's not. I remember going to school in my master's training and they taught us about stress. And they all said stress can be good and it can be bad. And they gave the generalized, simplified example for us to just categorize it in our minds, in that bad stress is an example of bad stress would be a death of a loved one or losing a job. And good stress was getting married or having a baby. But now we see that even in the best circumstances, birth is not always a good stressor. And especially when you have to contend with racism. And that's what just came back to me today while you were speaking. And I want to get us to a place where birth is a good stressor, no matter what the race. And so when we talk about doing these screenings, basically the importance of it is that we want to provide an opportunity and space for women to go deeper into every aspect of their lives. And so in preparation for this webinar, I started to think about, like I said, my days in the hospital setting, working as a case manager, also as a home visitor, and how many times I screened women using the PHQ-9. And this isn't an assault against the PHQ-9. What I'm saying is that I was required to use the PHQ-9 to get a gauge as to whether someone was depressed or not. But anytime I was asked about that, what was asked of me was, did I do it or didn't I? And that's what I reported back. So that was the data that went back to whichever organization I was with. Did you do it or didn't you do it? But on the qualitative side of that, just as a social worker, I had assessed, yes, whether she was depressed or not from that screening, but what was going on? Did she have housing? What resources did she need? What was her family situation like? Was she working? Did she have supplies? All of the other things that surround that quantitative number. And I couldn't remember one instance where in my reporting, days of reporting, anyone asked me about that qualitative information. The quantitative aspects of that qualitative information may have been around, did you refer to this organization? How many referrals did you make? If she had a high score, was a referral made? So again, a checkbox. But what we have here is an opportunity to take that qualitative information from one individual. And if we can start cross-referencing some of that qualitative data that we're gathering, and we may not be storing anywhere as an organization. So yes, a woman has stated that she has anxiety, she has stress. Okay, but then we look, in addition to that, is she having housing issues? Is there food security? Is there domestic violence? And then as an organization, starting to look at the rates in which women are depressed and having housing issues, women are depressed and having food insecurities, and then start to figure out from a programmatic organizational standpoint, if we're crossing reference and seeing higher rates of depression among women who are having housing issues, higher rates of depression around women who are experiencing within our organization food insecurity, how can we start to tailor some of that programming? Yes, we want to address the depression, but we want to start to contextualize and look at some of the intersectionality pieces and the points of the social determinants of health that might be impacting this. So can we start tailoring our programming around what some of those things are, whether it's through advocating, teaching our families and how to advocate for better housing, meeting with housing authorities, making sure that we have a better understanding and communication, means of communication with other organizations outside of ourselves. Because I guarantee you, we can continue to treat the chemical or clinical depression, continue to treat the clinical, whether anxiety, the clinical stress, but we still have those stressors, like she stated, that's still making women feel a certain way. Still women are being exposed and having those exposures. So when I talk about moving from screening to data impacting organizational program and community-wide interventions, it's just basically that. We talked about the AIM-CCI program, and I believe someone, Karen was on the call, I think I just saw pop up in the chat, through National Healthy Start has a cooperative agreement with the Human Resources Services Administration, HRSA, to do a program called, to pilot the Alliance for Innovation in Maternal Health Community Care Initiative, which is AIM-CCI, and that's a program in which we work. And with every AIM-CCI pilot community, we've asked them to establish a local maternal safety work group, or an LMSW. As an LMSW, I always think it's licensed maternal social worker, but it's not. It's a local maternity safety work group. So this is basically compiled of all of the organizations within a community that are here to address maternal health outcomes. And it's thinking outside of the box of just your Healthy Starts or your FQHCs or your WIC programs. You're looking at your faith-based organizations. All of these areas and social determinant organizations that women are speaking about, housing departments, police departments, all sitting at this table. So where you might think as one organization, or you just have your individual screenings and you just have your organizational data, you're now bringing all of this information to the table to start developing community-wide interventions, to start to address some of those stressors that we can no longer use we can't use our coping mechanisms to navigate any longer because it's becoming too much. So these are ways that we can take just one individual screening and how that one screening can be like that pebble in the river where it causes that ripple effect, to now you're having community-wide interventions to impact the families that you are serving real time with resources, referrals, but then also impacting the community as a whole. Because when we talk about vicarious stress, that's not something that one organization can address. That is something that collectively organizations need to be at the table to try to address and start to work against some of those vicarious stresses, whether it's we're seeing police brutality, we're seeing acts of violence. And even also on these LMSWs, we bring in hospital settings, because you can't just discharge a woman like I did from the hospital with a list of resources and maybe a crib or a pack and play or a car seat and send her out into the world, where the main issue is that she had no baby supplies. She had no resources to acquire baby supplies. But I've done my job because I sent her out. Now, one of the things I did to start to see what was going on and to address some of that qualitative things that I would get is that I signed up with the hospital's home visiting organization. And that's how I became a home visitor, because I kept thinking I could be doing more. We as a hospital could be doing more. So having that revolving door where I was the conduit from the community coming inside of the hospital, and then the hospital going back into the community to try to address some of those issues. So one person, one woman can make a difference if we start to collectively look at what our families are saying to us and why and how. Next slide, please. So these are some of the resources we talked about today. Dr. Jackson talked about the contextualized stress measure that she's created. We talked about the AIM CCI program. We're in the process of piloting a maternal mental health bundle that helps you start to establish some of these community-wide infrastructures, these resource and referral mechanisms, how to have that community clinical community integration, how to do those things, whether it's just organization to organization. Sometimes we don't have the resources to start to build an entire LMSW within a time frame that you think is going to be impactful. But what happens is it takes time, and we understand that, but you can still start to do the formula to reach out from organization to organization and start to look at some of the ways you can start to capture that qualitative data that I guarantee you all of your employees are getting, but may not be reporting because it's part of our job function. It's part of our job functions to find that out as community health workers or social workers. It's part of our job function. So we are getting information from our families, from the women that we're serving. We just need to see how we can utilize that and then arm ourselves with better information and better ways to intervene. And then HRSA also has a maternal mental health hotline, where it provides 24/7 free confidential support before, during, and after pregnancy. It is interpreters are available in 60 languages. Counselors speak English and Spanish. It's supposedly culturally sensitive, and it provides referrals and resources to local and telehealth providers and support groups. So these are just some resources that we know that are available. We know that in each and every community that you've listed in that introduction we did today, we know that there might be additional resources that aren't here, but these are just broad nationwide resources that can be available. So in the interest of time, I just wanted to make sure that we saved a little bit of time for Q&A, as I'm sure you all will have. But I also wanted to give Dr. Jackson an opportunity to chime in on anything I've said or move us right into the QA session.
Thank you so much, Deidre. And again, it's just been such a pleasure and honor to be a part of this team. I think we are certainly at the point in which we can burst out into new horizons in terms of how we assess and screen both qualitatively and qualitatively. The JHP is certainly one of those opportunities for seeing what is going on around stressors and what stress mediators are being employed and how individuals are responding, because clearly the effective responses is certainly an entry point for clinical intervention. Extreme isolation, anger suppression, clearly are areas that clinicians certainly do address in those kinds of settings. I just would like to hear, as we move into this phase, what are the approaches that the sites are taking, because I do believe in community-based participatory. I believe that they are the authoritative voices among individuals who see the communities that they serve every day in terms of what their needs are. And I believe that we can come together, put our heads together for new things that will be even more impactful. And this is the opportunity. So what you said was very, very important, because it's clear that individuals do not have the wherewithal or the resources to mitigate gendered racism. That's not an individual kind of thing that can be addressed. That requires community level, structural level, macro, all of those levels in order to do that. And so, but in order for us to do that, we have to have a way of seeing what the trends and patterns are within these communities. JHP gives one opportunity, but what you said in terms of qualitative data that's collected, that's really you don't have the full opportunity to really talk about, unless it's something dramatic.
Yes.
Unless something's dramatic. I was thinking about when Freddie Gray in Baltimore and the upheaval that took place. And, you know, I love Healthy Start. I love Healthy Starts everywhere. But I was thinking about Belly Buddies, who had a structure in place where they could bring those individuals together to say, okay, you know, let's ease your stress. Let's see how we can come together, support each other. So it's going to be important that we replicate those kinds of things. But in the first place, we know what's going on. Some of it will be so explosive that everybody will know it. Some of it will be from the qualitative that you talked about as in case management. Some of it might be through a JHP measure that will give you that information. But the bottom line is that we understand that that is critical in this effort to bring together the clinical and community for better outcomes.
Brittany or Iman, were there any questions that you saw in the chat, or raise your hand? I see. Go ahead, I'm sorry.
Janet O'Hara, I see her.
Too.
Okay. There's no not seeing me. I put it in the chat box, but I'd like to raise it again. I work for the Brooklyn Perinatal. We have a state-funded 12-week home visiting program that does community health workers and all kinds of concrete services. It's lovely. Social worker's dream. However, I'm supposed to develop a mental health program to tide them over between when we refer them to mental health and when they get there. And so there's all kinds of stuff going on with that. And one thing I've had trouble with my superiors about is that I think part of our intake for all our patients for this program should be a routine psychosocial, qualitative psychosocial, and go on from there. What we're doing, they're saying, oh, that's not necessary. Not everybody has problems. Anybody having a baby needs a psychosocial, I think. Because there's all this stuff going on. Can you say something I can tell to my betters?
You said you're with Brooklyn Perinatal? Yes. I'm familiar with them very much. I'm very disappointed that this is the new.
No, that their hearts are in the right place. They just don't get it. They think that the community health workers are always going to be able to pick up anyone who needs mental health services, and they do. They often do, but it takes them a long time. It takes trust. Right. Whereas I am very good at getting people to tell me things from the get-go, because that's what I do. I've done this for years. So is there any way to try to tell them this is not a stupid luxury, that this is not a waste of time?
It's not a luxury. The literature is filled with the, I'm trying to think of the word, with the positive aspects or positive benefits of universal screening. So
I don't mean screening, I mean assessment.
Screening and assessment, universal, right? Universal psychosocial assessment, universal screening. The literature is not promoting that we don't do that. So there's nothing that states in the literature like we should not be doing that. What I'm saying to you is that a lot of times when we're developing programs, especially with me being on this side of program development, and then also in academia now, as someone who practiced social work in these settings, there was very rare times that I went back to the literature and looked at studies to develop programs, and programs weren't always developed with the studies that are, so we're not speaking to one another. So the one thing I would do is suggest is that it's not just you saying, it's not just you yourself saying we should do this. It's not just another community health worker or another employee saying that. The literature, the data, quality improvement is stating that this is beneficial for families because of X, Y, and Z. And off the
Can you
top
give
of
me
my
one
head, I was
citation
about to
off the-
say, off the top of my head, before you could say that, off the top of my head, I could not think of a specific study, but as we're speaking, I'm sure something will come to me, but also
Okay.
I will put my information in the chat for you to reach out to me
Thank
directly
you
so that I
much.
can get you that information. But it's
Thank you,
not, it's very, what I'm saying is the concept in what you're speaking of is not something that has not been studied and proven to be beneficial, but we don't always speak the same language when it comes to academia and programs. We are doing real-time on the ground work in programs, but we need to understand there are people that have studied to say what we're doing and the way that we're doing it works because of X, Y, and Z. I'm putting my information in the chart. I mean, not the chart, the chat. Geez, you got me back to my days in the hospital. Is there a hand raised or another question?
Yes,
Dr.
I do
Jackson,
see a question from Ada. It says, I enjoyed this presentation a lot. What are your thoughts on when some women are displaying physical symptoms of stress, but may not say anything about it to the point where they may not be qualitative data on that individual as a stress coping response? They may dismiss their stress.
Thank you, Ada. And when you say physical, are you talking about something like internal, like high blood pressure or something like that? Or are you talking about you physically can see from looking at them signs and symptoms of stress-related issues?
Yeah, sorry, I meant to put symptoms, but yes, you physically see that they're under distress. What you perceive to be distress. Over.
So one of the things I used to do is, and I can't say that this is a verified technique or whatever, but you just want to make sure that in establishing rapport and relationship with your clients, I would always start, if I saw that, to say, you know what if we start by doing like a breathing exercise? You know, what if we start by taking a pulse or a pause, doing some techniques, and as they start to do that with you, then you coax them into how they can start to do these types of stress relieving things, and then what effects stress has on the body, even if they're not thinking it. You don't want to tell someone that they're having something, even if they say they're not. But by gently approaching the topic, by go ahead and emulating or modeling those techniques that they can start to do real time, then it sort of relieves when they see, oh, okay, I did need a breath. I didn't realize I need a breath. I'm drinking water. Sometimes we don't even remember to drink water. One of the things I have to do is I have to remember to actually blink because I'm constantly looking at the computer screen. And, so these are things now that we don't necessarily see as signs of stress. You're laughing at it, but it's true. I went to the doctor with dry eyes and she was like, how often do you blink? I'm like, who counts how often they blink? And the question was from that, how long are you at the computer? If I'm talking and I'm on screen and you see me doing this quite a bit, someone in my meetings will say, Deidre, what is this? I have to remember that these things aren't normal, but we're so used to trucking along in life and being taught that you're supposed to push through, because someone mentioned in the chat just briefly that resiliency. We're taught to be resilient even in the midst of, sometimes we need a break. My theory of preference in terms of my work is anti-racism. Self-care is a tenet of anti-racism. And we don't recognize that a lot of times, that we need to take care of ourselves. We're not taught that. So even in doing that and emulating and working with them and just saying, take a breath, let's take a breath together. You just came in, you just told me, whoa, that story was a lot. Oh, let's just take a minute and just breathe. 5, 4, 3, 2, 1, 1, 2, 3, 4, 5. It gives them the opportunity and the permission to take a breath. So it doesn't even have to be something that you physically see. If you start doing this in your assessments with your clients, they'll look forward to that and they'll start to internalize it. Because after they've unloaded, everybody needs a breath. You need a breath and they need a breath. So that's one way to introduce the conversation. And that's under mindfulness. That technique is under mindfulness, if somebody wanted to look up different ways to do that, or why we should be doing that. Dr. Jackson, I know she got, oh, you're back. Someone in the chat says, is the JHP measure ready to be used? And what are the qualifications of the examiner administrator? And which settings do you recommend to administer and collect the measure? That was like 4 questions, but we can do it.
Okay, that was 4 questions. Yes, you can use it. No, there's not any particular qualifications for it. Part of the delay has to try to figure out how to put it online so it's easier administered, because it's more pen and paper now, so that you can check it all, get a total score, and see whether somebody has high, moderate, or low JHP. But within that, what are the specific things that make them high or low? We have a link for you to have access to it, and with more information to come. So I hope that answers you.
I'm just looking through quickly. I don't see.
I think, Deidre, I think that's the only questions in the chat.
And I will say that as part of the resources, there's a toolkit on stress and mental health up and ready to go. There's a toolkit that goes through a number of the things that I talked about in terms of chronic, acute and traumatic stress. And it also talked about depression, and also some information about with fathers and males around depression. But also some interventions for individuals to employ, going from diet to exercise and those kinds of approaches, as including clinical care.
Someone just asked, where do we get it? Are you asking, Janet, where do we get the tool, or what Dr. Jackson's tool, or what she just spoke about?
The toolkit.
Oh, the toolkit.
It's right on the, isn't it on our, I don't know if it's up yet, if it's ready.
Okay. One of the things we wanted to do before we left, and I know a lot of times you get this in the evaluation, but we want to move to action. You know, we're trying to do transformation. So we want to always be moving towards action. So we just wanted to take another poll, next slide, and just sort of gauge based upon some of the things you've learned today. What do you think is one action step that you can take from this webinar back to your organization? Just based upon some of the things that we've discussed. I know, Janet, you talked about, you'll be in communication with me about taking back some of that literature and data as to why doing screenings and assessments are important. And this isn't just to put you in a box or anything. There's a ton of other things that can be done, but we want people to leave here not saying, oh, this was a great this was a great presentation, which a lot of times we do. We want to sort of move to action, what we can do next. What are some of the ways we can take this information and bring it back so that this webinar is not just informative, but it's transformative. And also it gives us an information as to what are some of the things that we've discussed that you might like to embark on as we create our strategies of how to better serve you and get information to you as well as to what you might need next. Awesome. Just seeing if we can get like 50%, but I see where things are going. Awesome. right. Brittany, if you wanted to, it's about 55%. I know people are dropping off, 56%. So we can go ahead and share the results. So it looks like the majority of you are interested in developing strategies with other community-based organizations to address maternal mental health issues within the community. And that's excellent. As we're continuing to develop that maternal mental health bundle, this is one of the core tenets that we talk about with the AIM CCI program, the local maternal safety work group that I discussed. This is one of the main strategies and reasons for doing this and coming together to the table is to make sure you're doing collective interventions for women and children. And so it's great to see that that's one of the main strategies that you all would like to take away from this. And then following that, looking at your screening tools to gain a better understanding of how to address client needs using a contextualized approach, which to me says that when we started this, we wanted to give you ways to look at this differently and also give you an approach of how to make a community-wide impact. And it looks like those are the two main things that you're going to try to do when you leave here today. So with that, I say thank you. I'll pass it back over to Brittany if there's any other closing remarks from Healthy Start. It's been a pleasure.
Yes, it has been a pleasure.
Speaking and presenting with you all today, and just continue to look at the websites as we move forward and continue to do new products and also have more offerings.
Thank you.
Yes. Thank you so much, Dr. Jackson and Deidre, for taking the time to share this vital information about stress, about mental health, about things that tools and ways that can be utilized to help women throughout the process of pregnancy and after. We just a quick question for Dr. Jackson and Deidre, could we share this PowerPoint with the people who were attending? Because I'm sure some of them will email us and ask if we can share the slides with them.
That's fine.
Sure.
Oh, awesome. And again, the recording will be available in a couple of days. We'll also be sending an evaluation survey, just a few questions, just to help us better understand how the format of the webinar is effective for those that are viewing. So look out for that email. It'll be the link to the recording, the PowerPoint slides, and a link to a quick survey. Again, thank you, Deidre. Thank you, Dr. Jackson. It was such a pleasure. Learned so much, took lots of notes, and I'm sure everyone else did just the same. Thank you guys for joining us, and we will see you next month for the next Women's Health Series webinar.
Thank you.
Bye-bye.
Bye, everyone.